Good morning. I think we'll start the Dr S Mohandas pre-paper award section. There are 5 papers in this thing, and time allotted for each paper is 7 minutes. There will be a warning signal 1 minute before the end of the allotted time, and the time allotted for discussion is 1 minute. Okay, first.
Go ahead, sir. Usually, sir calls. Sir will call.
Okay.
No problem. Sir, you can tell something. 1 minute. 1 minute.
So the first speaker is Midun Tulasidas. It's comparison of superior inferior laser peripheral irectomies in primary angle closure disease.
Respected chair and delegates, wish you all a very good morning. So I thank KSOS for giving me this opportunity. Today I'll be presenting on comparison of superior and inferior laser peripheral iridotomies in primary angle closure disease. I have no financial interest. So as we all know, laser peripheral iridotomy is the primary treatment for angle closure glaucoma caused by relative or absolute pupillary block. And conventionally we used to perform this procedure in the superior quadrant between 10 and 2 o'clock usually. But there have been studies reported which implicated the location of the iridotomy proximate to the eyelid margin as the cause of dysphotopsia, that is mainly due to the refraction of the tear film by the lid margin, and this was more commonly seen with the superior LPIs. Inferior peripheral iridectomy have been conventionally performed in patients who are undergone retinal surgeries, mainly those who received silicone oil. However, the efficacy of inferior laser peripheral iridotomy in primary angle closure disease was not studied in the Indian population. So the purpose of the study was to compare the side effects and efficacy of superior and inferior LPI in patients who had presented with PSCD. This was a prospective randomized single-masked single-center study. The inclusion criteria was based on the International Society of Geographical and Epidemiological Ophthalmology. Those who were PAC and PSCG were included. Among those who were diagnosed as PSCs, only those who had a family history of glaucoma or a contralateral eye with angle closure glaucoma or an ITC, that is iridotrabecular contact of 360 degrees, were included. These were the exclusion criteria. So the randomization was done using a binary random number generator. One eye was randomized to an LPI in the superior or inferior location, and the other eye by default was assigned the opposite location. The patients were actually masked, so it becomes a single masked study. Group 1 included eyes who had superior LPI and group 2 included eyes who had inferior LPI. And we have used the laser energy setting between 1 millijoule and 3 millijoule depending upon the thickness of the iris. The energy was determined by multiplying the energy per shot into the number of shots. Topical corticosteroid was used for a week post-procedure, and follow-up was done on day 1, 1 week, 1 month, 3 months, and 6 months. The primary outcome measures included the patency of iridotomy and the intraocular pressure, whereas secondary outcome measure included the visual side effects. The statistical methods included a paired t-test, chi-square test, and a p-value less than 0.05 was considered as significant. So initially we have screened 184 subjects, out of which 28 did not meet the criteria and 4 withdrew consent. So then we finally included 152 patients which were either randomized to superior LPI or inferior LPI group. So basically 304 eyes were analyzed with 152 eyes in each group. So this shows the slit lamp images of 2 patients who had undergone the inferior peripheral iridotomy at 5 o'clock and 7 o'clock. These are the demographic characteristics of the study population. Coming to the primary outcome measure, all the iridotomies were patent based on the gonioscopy finding and on ASOCT when we see a full thickness perforation of the iris. Intraocular pressure, both the groups showed a significant decline after the procedure. However, the intergroup difference was not statistically significant. To our surprise, the laser energy used was more in the superior LPI group compared to the inferior LPI, and this was statistically significant. The major side effects included iris bleeding, transient IOP elevation, iritis, which we defined as cells 2 plus and more, and linear dysphotopsia. Out of which iritis was the only side effect which was statistically showed a difference between the two groups, that is 58% in group 1 and 43% in group 2. 2 eyes reported linear dysphotopsia in both the groups. There were studies which compared superior and temporal laser peripheral iodotomy in the literature, and the initial one by Vera et al. Actually showed that the superior alpheas are more prone for linear dysphotopsia than the temporal ones, but the later study showed no significant differences between the position of the alpha and the visual disturbances. However, both these studies also pointed out that a superior alpha required more energy compared to the temporal or nasal LPI. We in our study found that the energy and number of shots required to perform LPA was more with the superior approach, but with no difference in the visual side effects. In our study, the iris bleeding was actually minimal, which was seen only in 17% of the cases compared to the reported incidence of 45%. And we also noted that during the superior LPA, when the bleeding appears, the visualization is difficult for the further shots. And the chances of an air bubble formation are also more. Superior LPA resulted in a higher incidence of post-laser iritis, which could be due to an increase in the energy used, and this was similar to the finding by Ahmadi et al. Inferior LPAs, on the other hand, required fewer shots and less power, providing easier access to the surgeon, and this could be possibly due to the patient factor, because most of the time the patient forcibly tries to close the eye, and there is a tendency for the eyeball to rotate upwards. So an inferior LPA is usually preferable in patients with dense arcus and thick iris due to easier access and better visualization, and there was no significant difference in visual dysphotopsia post-procedure. And to the best of our knowledge, this was the first study to assess the utility of inferior LPA in ankle closure disease in Indian population. The strength of the study included the study design, which was a randomized single-mass study, and also the inclusion of the entire spectrum of ankle closure disease. However, the study does have a few limitations. A questionnaire to evaluate patient satisfaction would have added more information, and the use of KSOCT to evaluate the parameters pre and post procedure could have been included. To conclude, both superior and inferior LPAs were equally effective, but with no significant difference in visual side effects. However, the laser energy required was left with inferior approach. Thank you for your kind attention.
You said the iritis is less than inferior.
Yes, sir.
So that is 2 plus cells you calculated.
Yes, sir.
Which day you evaluated? On the first day?
Yes, sir. Day one.
Day one.
Yes. Because so, almost all the iritis resolved after a week of topical steroids.
You said the reason is less energy, no?
Yes, sir,
that could be one.
Yes.
Another reason could be when you apply it superiorly
the pigments actually fall down.
You will come, you will see
Definitely,
that, because that also you can, that reason for that.
Yes.
Then why you want to do this study of
no, sir,
inferior?
Like most of the time in our practice, we end up doing it mostly sometimes in the inferior quadrant also, because we could not find the proper crypt in the superior and also the access. Because sometimes when the patient actually, like I said, when the patient tries to force the eyelid, the patient tends to look upwards. And when we actually aim the laser beam, when it enters the iris crypt in an oblique way, the chances of perforation are less, because then we have to apply more shots when it is in the superior. Whereas this is much easier in the inferior. So actually we initially start understood this difference when we did a few cases inferiorly. Then we thought, why can't we compare? Because there were studies actually, even though you say the energy performed is less, superior and temporal LPA comparison also came in the similar way, because initially people were telling like the temporal approach should be avoided. We should always do it in the superior so that the lid margin will cover the hole and avoid the side effects. But later what came out was like the side effects were more with the superior compared to the temporal because of the positioning. So in that way, the take-home message is basically you can perform it in any quadrant when you find the crypt is easily accessible, and an inferior will work as good as a superior LPA.
You said dysphotopsia.
Yes, sir.
Why was the dysphotopsia there?
No, sir, because that is the most common side effect which actually irritates the patient after the iridotomy. Because otherwise we tell the patient like most of the time the iridotomies are safe and there are no side effects, but sometimes the patient come up with this side effect which is actually very difficult to treat also.
Why did you know, only patients with family history you included?
In PACS group, only those with a family history, because like the recent ZAP trial showed us that there is no point in doing a PI for every PACS patient. So in PACS category, suspect categories, those with a family history and those who had a contralateral eye which had an attack or angle closure glaucoma were actually included.
But you said one eye inferior PI, one eye superior.
Yes,
no?
sir.
Then if it had been an attack of acute congestive glaucoma,
Yes, sir.
then how would be easy to, you know, whether it is correct to include in your study?
No, so we have actually included even acute angle closure glaucomas in the study. Like the criteria included both PACS, PAC, and PACG.
Okay, so-
like all three.
So simultaneously you don't do the iridot. Supposing it's one attack, earlier they have done superior iridotomy or some iridotomy or something.
No, sir. Like the choosing of the eye was actually based on the randomization.
That's what I was, yeah.
That was based on randomization.
Where you could do both the eyes only.
Yes, sir, exactly.
Not
Not,
the,
one eye, because
So that
all the
means if
cases had both the eyes.
So if they had come to you for an acute attack, you would include.
Yes, sir, and also PAC with the raised IOP.
Now another thing is, what is the longest follow-up?
So we had 6 months follow.
That's all. That
was-
is too little.
Yes, sir. Yes, sir.
You need a longer follow-up to
Yes,
see
sir.
what is there.
Definitely.
Good study. Thank you.
Thank you, sir. Thank you.
Is there any chance of occlusion between the two?
Yes, that the actual answer for that we can make out with an ASOCD if you compare the parameters. Because even though in studies where we have compared superior and temporal, even though they say temporal is easier, it has found that the opening was more with a superior approach. So actually, we are actually planning for a different study where we actually analyze each parameter like the angle opening distance and TISA to see whether the opening is better with superior or inferior. Thank you.
Yeah, thank you. The next speaker is Dr. Latika VK, and she'll be talking on impact of glycemic status on CCT and IOP in diabetic patients, a prospective study.
Good morning, respected judges and dear friends. I thank KSOS for the opportunity. Today, I'll be presenting a paper on the impact of glycemic status on central corneal thickness and intraocular pressure in diabetic patients. So, the unholy nexus between diabetes and glaucoma is well known. Prevalence of glaucoma itself is quite high in diabetics. So, glycemic status can influence CCT and CCT influences IOP. So, it is only a logical conclusion that glycemic status influences IOP. But the question what nagged us was, having known all this, are we actually factoring in this knowledge for the benefit of patients? Are we considering blood sugar levels while making glaucoma-related decisions in diabetic patients? This is what prompted us to do this study, because the reports suggest variable links between these three parameters, and there are no lucid recommendations that we can make out from these reports on how actually to translate it into practice, whether it is the FBS or the PPBS or the HbA1c, what we should be looking at. So that is why we designed the study to study the impact of glycemic status on CCT and intraocular pressure in patients with diabetes. It was a prospective observational study done in a tertiary care teaching hospital over 18 months on a sample of 60 patients who were recruited by consecutive sampling. And the patients we recruited were all uncontrolled diabetics with a PPBS of more than 200 and HbA1c of more than 7. Any pathologies that could alter the corneoscleral architecture, high refractive errors, long-term ocular medications or steroids, systemic diseases that could influence IOP, and patients who were unable to be positioned for ideal ocular examinations were excluded from the study. So the study group underwent a complete ocular examination, and we measured the CCT using the Carl Zeiss SDA's OCT Fiolan raster mode, and the IOP was measured using the Goldman applanation tonometry. Glycemic status was recorded and control advised, and follow-up was done at 1 week and then after 12 weeks, that is 3 months. So at each follow-up visit, all these things were repeated by the same examiner and data analyzed using the SPSS23 software. So changes in CCT and IOP were basically analyzed using the pair t-test between each visit and ANOVA test across the 3 visits, and a p-value of less than 0.05 considered significant. The mean age of the study was 58.5. Most of them were over 50 years of age, and males constituted 63.3%. Most of the diabetic age was around 5 years or less. So coming to the actual results, we first looked at how the glycemic level changed over 3 months. And both FBS and PPBS showed a statistically significant drop from baseline at a follow-up visit of 1 week and also at 3 months. But what I want you to focus on is that this drop was mostly in the immediate phase. That is, both FBS and PPBS went down drastically in the first week itself after proper treatment was initiated. Whereas the HbA1c decreased by about 4, it took around 3 months for the HbA1c to come down. So we looked at whether CCT changes paralleled the glycemic status changes. So what we found was that there was a statistically significant variation in CCT across the 3 visits. However, the mean difference in CCT between baseline and 1 week did not parallel the glycemic control that was obtained during that period. In fact, the CCT came down only after 3 months. The same happened with IOP also. So the IOP trend was parallel to the CCT trend. The IOP did show a decrease after 3 months, but not after 1 week. It did not parallel the sharp drop in glycemic status. So we have other studies which have come up with similar findings as ours, in the sense that the CCT has been found to be higher in hyperglycemic states and in diabetic populations. And there are some studies which are in discordance with us also. But the actual influence of FBS and PPBS and HbA1c has not been compared to each other. Our study has had certain limitations and strengths. The design of the study, wherein we follow up the same cohort of patients over time, minimizes other confounders affecting these results. That is one thing. And secondly, it is a reflection of the real life situation that we are facing, where we are following up the same glaucoma patient over time. So it makes sense to replicate that particular situation in a study design. So these two are the strengths of our study, whereas we did not do a specular microscopy and we do not know the corneal endothelial status of these patients or the mechanism. Doing that would have contributed potential insights on the underlying corneal changes as well. So to conclude, optimal glycemic control did lead to a notable reduction in CCT values and IOP values. Short-term glycemic fluctuations as measured by FBS, PPBS did not influence either of these parameters significantly. Stable euglycemia, as evidenced by hemoglobin A1c levels at 3 months, produced significant drops in CCT and IOP measurements. And so stable glycemic status is essential for a reliable IOP measurement in diabetic patients. So what is new about this? The new thing is that, as I said, the relative significance of FBS, PPBS and HbA1c on CCT or IOP was explored in detail, and the design involving a single cohort reflects real-life scenario. This study gives clear-cut evidence on how frequently a clinician should assess glycemic control in the context of glaucoma diagnosis and management. We know that Kerala is the diabetic capital of the world, so we have to translate this into evidence-based medicine, and we recommend that healthcare providers should look into glycemic status, specifically HbA1c, at least once in 3 months when you follow up the glaucoma patients and make glaucoma-related decisions in diabetic patients. FBS, PPBS monitoring at each visit, however, is neither necessary nor practical. These are my references, and I thank you for your kind attention.
Good thinking, Ma, and good. You projected well and presented well.
Thank you.
So, as you say, the CCT level varies with your glycemic status. So you will make your correction also, no IOP calculation.
I have not found out the factor by which the glycemic status produces a corresponding correction. Actually, if we can find out how much is the actual relation, we can probably think of correction
That's what
tables.
you're showing the thickness.
Yes.
When it goes to correction, what is the proportionate change?
Per unit change, if we can calculate, it would be very useful to make correction table. That
And
might
correlate
be
with your HbA1c.
Exactly.
It will be as you said correctly, FBS and PPBS is
Doesn't make
transient.
sense,
It
yes.
doesn't make sense. It will be good, but only thing every 3 months.
everything, and it is
HbA1c is not only good for the eye, it is good for the patient also.
exactly. So
Put that
it is
way.
practical.
Correct. Good study, ma.
Thank you, sir.
Is there any, did you look into the HbA1c levels and central corneal thickness? Levels of, you selected all patients with more than 7 or?
Yes, that's what
did
I
you
did.
calculated the status of the HbA1c and the central corneal thickness? Is there any relationship between the?
Yes, there is actually HbA1c levels. When the HbA1c levels come down, only the corneal, and when it is going more than 9%, it is becoming more significant.
That also you calculated?
Yes, that cutoff. Yes, it was there. We did look
You
at that.
included diabetic patients with glaucoma or?
No, we included just diabetic patients.
Diabetic patients.
Yes, because even in the screening, this becomes important, not only in the diagnosis. So we included diabetic population as such.
So thickness increases. What is your theory? Is the edema?
Actually, the literature shows up some mechanisms by which the corneal CCT increases.
That time we had to think about
Yes.
corneal hysteresis.
Yes,
also.
but we could not assess the corneal thickness in this population because we didn't have a specular microscope.
Okay, thank you.
Thank you so much.
Next, we have Dr. Shiksha Suresh, and who will be talking on assessment of change in foveal avascular zone area in POAG and PACG patients after glaucoma surgery.
Good morning. My topic is on assessment of change in foveal avascular zone area in POAG and PACG patients after glaucoma surgery. Foveal avascular zone is the round capillary free zone within the macula. It is usually delineated by fundus fluorescent angiography, which is an invasive procedure. Nowadays, OCT angiography, which is a non-invasive procedure, is used for assessing foveal avascular zone. It allows depth-selective visualization of retinal and choroidal vascular networks by detecting the endoluminal blood flow. There is limited exploration of FAZ behavior in different types of glaucoma, specifically PACG. So, investigating how FAZ area changes differ between POAG and PACG patient can provide insight into the pathophysiology and responses to surgical intervention. Aim and objectives are to assess changes in foveal avascular zone area in POAG and PACG patients following glaucoma surgery using OCT angiography and to correlate changes in the foveal avascular zone area with changes in the IOP in POAG and PACG patients. Study site was Glaucoma Department Combe Trust. Study population POAG and PACG patients undergoing glaucoma surgery. It was a prospective observational study. All patients, POAG and PACG patients undergoing IOP lowering surgery, either TRAB or phacotrabeculectomy was included in the study. Eyes with significant ocular pathologies that bias FAZ area was excluded. History of ocular trauma, uveitis, Parkinson's disease, Alzheimer's disease, stroke, trabeculectomy with complications and poor quality scans were excluded. All patients underwent a detailed history. Anterior and posterior segment evaluation was done. IOP gonioscopy was done. HFA and OCT RNF was taken and they underwent OCT angiography. OCT angiography was used to assess foveal avascular zone area preoperatively as well as 3 months postoperatively. In both superficial as well as deep plexus, 2 examiners manually measured the foveal contours and the average of the 2 readings was taken. IOP and FAZ area was measured 3 months postoperatively. Total sample size was 41, which included 23 POAG and 18 PACG patients. Preoperative and postoperative IOP in POAG and PACG patients and change in IOP. We can see in both POAG and PACG patients there was a reduction in IOP with a change in IOP statistically significant in both the groups. In effaced area in superficial vascular plexus preoperatively and postoperatively, there was a reduction in effaced area in the superficial vascular plexus, but the change in effaced area in POAG group was statistically significant when compared to PACG groups. When it comes to deep vascular plexus, effaced area was reduced with both change in effaced area in POAG and PACG group statistically significant. A correlation between change in effaced area in superficial vascular plexus and change in IOP. In both the groups, there was a weak negative correlation, but it was not statistically significant. When it comes to deep vascular plexus, in PACG groups, there was a negative correlation which was statistically significant. So our study found out that effaced area was decreased in both superficial and deep vascular plexus after glaucoma surgery in both PACG as well as POAG patients, and the changes in IOP and effaced area in deep vascular plexus in PACG patients showed significant negative correlation. According to our study, deep vascular plexus showed a more significant reduction when compared to superficial vascular plexus. This suggests that the deep vascular plexus is more sensitive to IOP lowering procedure. Also, it highlights the potential of effaced deep vascular plexus as an indicator, prognostic indicator of microvascular improvement after glaucoma surgery. Also, this underscores the importance of analyzing both the superficial as well as deep vascular plexus separately in future studies. According to Takoi Shoji et al., effaced area in superficial vascular plexus was significantly decreased, and they proposed that it was due to enhancement of the perifoveal microvasculature with restoration of the macular retinal ganglion cell function after IOP lowering. According to H.Y. Park et al., there was a decrease in effaced area in the deep vascular plexus. Tune Von Chang et al. Study was slightly different from our study, where they found out that there was an increase in the effaced area at 1 month which reverted back to normal. They have said that this increase may be due to surgical inflammation, and the surgical inflammation can result in poor quality scans, and our study has excluded poor quality scans. So our study concluded that foveal avascular zone area in both superficial vascular plexus and deep vascular plexus was decreased after combined cataract and trabecular surgery in both PACG and POAG patients, and the significant reduction in IOP and the associated changes in effaced area suggest that glaucoma surgery may improve retinal perfusion. So what this study adds to literature is that it strengthens the understanding of how lowering IOP with trabeculectomy affects retinal vascular health, and employing a non-invasive modality like OCTA for predicting prognosis following glaucoma surgery. Unlike previous studies, this study highlighted the differential vascular response in superficial and deep vascular plexus, which is relatively a novel aspect in glaucoma research. The limitations are duration of follow-up should have been longer with larger sample size. Measurement of effaced area may be influenced by combined cataract surgery, and measurement of effaced area was done manually by tracing effaced contours, which may cause errors. So future studies with larger sample size and longer duration of follow-up is recommended to analyze the clinical implications as well as to explore the utility of OCTA. These are my references. Thank you.
What was the pressure difference? I didn't get it actually. Pre-op and post-op, how many millimeters average?
So this was,
yeah.
So there was a decrease of 7 mmHg.
7 mm.
7 both the groups.
So it's your study. This was done at 3 months time. Another study 1 month. That's a transient increase you showed.
Yes, sir.
You know? So whether that reflects anywhere in the field or any other functional quality?
No, sir.
No. Whether it's analyzed?
No, sir. It was not analyzed.
Not analyzed. So suppose whether this can happen in medical control also?
Sir,
Medicine. Say if you start treating a patient without surgery, suppose a patient having 30 IOP, you medically control it, whether this can happen?
Sir, actually IOP lowering can cause, it can increase the ocular perfusion pressure, but I haven't tested for that, sir.
And another aspect I want to see that how many of these patients had a prostaglandin treated?
Sir, actually, most of the patients were treated with prostaglandin analogs only
No,
previously.
no separate class separation in this study.
No, sir.
Okay, thank you.
Good, ma.
Thank
I think there are many arms for this particular study, For example, the duration of duration of glaucoma, we don't know. So that is number one. Number two, reduction in FAZ. Your fields, your foveal threshold will also change.
sir.
That will be also a good parameter to study, when you extend the study.
Okay, sir.
Isn't it?
Yes, sir.
When
Yes,
FAZ is becoming better, your foveal threshold in your 24-2 or 30-2. So that will give more value for this also.
Okay, sir.
But overall, you are taking only surgery for POAG, PACG. As sir was asking, so, do you categorize them pre-op and post-op?
Yes, sir.
And the variation in pressure change also will vary. Does that have an effect? So you need to correlate, reducing up to 8 to 10 millimeters or reducing to 2-3 millimeters. Again, so multiple correlations you do, you will get better outcomes. Continue doing this. All the best.
Okay, sir.
So, how will you decide on this trabeculectomy or phacotrabeculectomy? In which all patients you do trab or trab alone and phacotrab?
Sir, if cataract is not dense, we do trab alone.
And for phacotrab patients, is it? Can you get this
Actually,
pre-op OCTA?
we have excluded poor quality scans.
Okay. Then how will you decide this POAG and NTG? Have you ruled out NTG?
Yes, sir. Yes, ma'am.
Okay. Then another is PACG surgery. They were on also medical management or directly angle closure?
No, ma'am. All were on
Chronic
medical
patients.
management.
All PACG were also chronic patients
Yes,
or
chronic patients only.
chronic CACG patients,
Yes,
not following an acute attack.
No, ma'am.
No vascular compromised
No,
like
ma'am.
that.
Next, Dr. Nimi George will be talking effects of long-term topical anti-glaucoma medications on dry eye syndrome.
Good morning, dear judges and audience. The topic of my study is effects of long-term topical anti-glaucoma medications on dry eye syndrome. Topical medications form the current first-line therapy for glaucoma because of its wide acceptance, but it can profoundly affect the tear film stability. The dry eye disease is one of the most prevalent eye conditions with an Indian prevalence of 32%, and iatrogenic causes like ocular surgery and topical medications are well proven. GOSD, or the glaucoma-related ocular surface disease, is a significant yet often underdiagnosed ocular comorbidity affecting nearly 60% of the glaucoma patients worldwide. The topical therapy can cause tear film abnormalities and instability of the ocular surface, which can adversely impact the patient compliance with therapy and overall quality of life. A word about LipiView. It's a novel investigation for dry eye. It operates on the principle of white light interferometry. It gives an objective assessment of the tear film blink dynamics, that is, it gives blink patterns and also a partial blink rate, and it also allows visualization of the meibomian glands. From LipiView, we get a value of LLT, that is lipid layer thickness, which when less than 60 nanometers is indicative of dry eye, and also we will get a partial blink rate, which when is more than 50% indicative of dry eye. Moving to my study proper, it was a cross-sectional study done over a period of 2 months in the age group of 50 to 75 years. I considered 110 eyes of 55 patients on AGM of any category for at least 1 year, and I compared it with 98 eyes of 49 controls. I excluded patients who were who had previous history of ocular surgeries other than cataract surgery, those with a past history of dry eye, those who were using other topical medications, and who had history of systemic conditions like Sjogren's syndrome or rheumatoid arthritis, which can predispose to dry eye. A questionnaire of symptoms were asked and a score out of 7 was given. T-BERT and Shimmer 1 test were performed for each eye. From lippy view, meibomian glands were visualized and meibomian gland dropout was graded from grade 1 to grade 4 as can be seen from the images, and also we obtained LLT, that is lipid layer thickness, and partial blink rate values for each eye. Moving to the results, the females predominated my study by 61%. Prostaglandin analog was the most commonly used anti-glaucoma medication and burning sensation was the most reported symptom. Compared to controls, the cases, that is the eyes on anti-glaucoma medications, had increased symptom score, increased MG dropout, reduced lipid layer thickness, and increased partial blink rate, all of which are indicating of dry eye more in eyes on anti-glaucoma medications. And all these were statistically significant too. But a correlation between the number of AGM and dry eye parameters, I could see that with increasing number of AGM, there was increasing MG dropout, reduced LLT, and increased partial blink rate. This is a bar diagram showing the same. As we can see here, with increasing number of AGM, there were higher grades of MG dropout. Next, a correlation between the duration of AGM usage and dry eye parameters. With longer duration of AGM, there were higher grades of MG dropout, reduced LLT, and reduced shimmer, which were statistically significant. I also did a comparison between the individual AGM on patients who were on monotherapy. I compared beta blockers, carbonic anhydrase inhibitors, and prostaglandin analogs. The mean duration was almost similar in the three groups. I could see that the PG analog group had increased MG dropout, reduced LLT, increased partial blink rate, and reduced T-BERT and shimmer. Moving to discussion, the difference in MG dropout score, partial blink rate, LLT, T-BERT, and shimmer values were explicit between the eyes treated with AGM and control eyes, which was similar to other previous studies. In the three monotherapy groups, the mean duration of the drops were almost similar, which might be the cause for lack of a significant difference in the dry eye parameters among the three groups. Also, we know the meibomian glands secrete lipids into the tear film, which contributes to tear stability and which is self-explanatory of the increased MG dropout eyes had a reduced T-BERT, which is seen in my study too. Study had limitations. Age and gender were major confounding factors because perimenopausal female are already predisposed for dry eye. The state of meibomian glands before the start of treatment was not known, so we are not sure about the pre-existing status of the meibomian glands. And the effects of AGM and preservatives could not be investigated separately as I didn't study any preservative-free drops. So to conclude, a long-term AGM usage can cause dry eye and our study supports the same. To the best of our knowledge, this is the first study of its kind done in our population. Prescribing minimum number of AGM to achieve target IOP can help in reducing the glaucoma-related ocular surface disease and which will definitely improve patient compliance to these medications, which in turn will reduce the progression of this potentially blinding illness. Thank you.
The main cause for ocular surface disorder is due to preservative. So is it necessary to see the preservative?
Yes, ma'am. We are planning a prospective study comparing difference between preserved and preservative-free drops. Prospective study would be better.
Yeah, so that is the because we all know the ocular surface is affected mainly because of the
Preservatives, BAK.
preservative, BAK. Okay, that is not you have not
I have not
included
considered.
that.
Yeah, your study would have been 3 times better if you had categorized the medicine. That is the idea. So between clinical evaluation, where we don't have the lippy view, and this, you say it is far more superior. But some one place you say this no dropout was nothing, but you had a T-but which was reduced. One of your statements, no? You found that also?
I know, sir, it was correlating, sir.
Correlating.
With increasing MG dropout, there was reduced T-but.
Okay. So it is all in lines with the existing studies, no?
Yeah, yes.
You have
yes,
not
sir.
shown all the studies.
Existing studies also between individual drugs, very few studies have compared.
No, did you show the studies in your
No,
presentation?
only
No,
just only the
you just
references.
mentioned. Thank you, ma. Good presentation.
Next, we have Dr. Revati KV talking on goniotomy with a single-use hook blade. Short-term results.
Good morning, judges and dear audience. My topic is on goniotomy with a single-use hook dual blade short-term results. Combining microinvasive glaucoma surgery with cataract surgery has gained popularity due to its better safety profile. Cahook dual blade is a single-use ophthalmic surgical blade designed to perform abentono-goniotomy and excision of the trabecular meshwork strip to restore the conventional aqueous outflow pathway. Our aim was to evaluate safety and efficacy of aquaemulsification with the KDB goniotomy in the treatment of mild to moderate primary open-angle glaucoma and primary angle closure glaucoma. It was a prospective observational study done at Tertiary Eye Care Center in Kerala with the 37 POAG and 20 PACG patient who had a glaucomatous field defect and visually significant cataract. Patient had an IOP of less than 30 mmHg and or were more than one anti-glaucoma medication. We excluded the secondary glaucoma patient with bleeding disorders and prior filtration surgeries. After collecting the demographic data, number and type of anti-glaucoma medications, Snellen's best corrected visual acuity, Goldman applanation tonometry, slit lamp biomicroscope examination was done, and Humphrey's visual field analyzer was used to categorize the glaucoma. All the surgeries were performed by a single experienced surgeon under peribulbar anesthesia. After a standard phaco emulsification with IOL implantation, the pupil was pharmacologically constricted and cohesive OVD was injected into the AC, and the KDB is inserted into the anterior chamber under direct gonioscopy, and the tip is guided into the nasal angle and inserted through the trabecular meshwork into the Slum's canal and advanced several clock hours. The same was repeated in the opposite direction. So each eye would be having a range of 110 to 140 degrees of trabecular meshwork excision. The postoperative care, the moxifloxacin eye drops QID for 1 week and prednisone acetate for 4 weeks. AGM was continued postoperatively and discontinued as indicated by IOP at each visit. Intraoperative and postoperative complications were noted, and IOP and number of AGM were noted. IOP reduction of more than or equal to 20% and or a reduction of 1 AGM was considered as success of the procedure. To analyze the changes of IOP over time, repeated measure ANOVA was performed and 2-case multiple comparison test was applied to identify specific differences. The results shown, PACG group 67.3 were the mean age, and in the PACG group 70% were females. In the POAG 68 was the mean age and 65% were female. Mean preoperative visual acuity was 0.7, which was improved to 0.08. A majority of the patients in the PACG and POAG group was having mild glaucoma. 75% in the PACG group and 86.5% in the POAG group had at least one AGM. The most common AGM was prostaglandin analog followed by beta blockers. The number of AGM before treatment in the PACG group was 1.4, which was reduced to 0.6, and in the POAG group was 1.2, which was reduced to 0.6, which was statistically significant after 6 months. In the IOP, the before treatment was 24 in the PACG group, which reduced to 15.2, and 24.3 in the POAG group, which reduced to 15.3 after 6 months. The percentage of more IOP reduction of more than 20% from the baseline IOP was 95% in PACG group, and 89.2 in the POAG group. The ultimate goal of glaucoma therapy is preservation of quality of life by reduced medication, improved ocular surface, and cost effectiveness and compliance. As a study done by Song et al., where they compared the phacogoniotomy and phacotrabeculectomy, have shown that comparable cumulative success rate, but the phacogoniotomy had a lower rate of postoperative complications and shorter surgery time with improved quality of life at 12 months. In our study, where we compared the POAG group with another similar study by Krishnamurthy et al., we have seen that the IOP reduced from 24.3 to 15.3, and the POAG, AGM was reduced from 1.2 to 0.6, which was similar. In the PACG group, all the patients with the PACG group had undergone YAG laser peripheral iridotomy and had a mean IOP of 24 before surgery, and all of them were on AGM. The PACG group LPA deepened the angle and thus may lower IOP, but the procedure alone is not typically adequate for the long-term IOP control and for visual acuity improvement. In eyes with angle closure glaucoma, trabecular meshwork may be permanently dysfunctional by chronic synechalization, inflammation, and proliferation of the fibrous tissue. Thereby, combining the cataract extraction with the KDB goniotomy will further remove this dysfunctional trabecular meshwork, reducing the IOP further. This was our study group compared with another two studies by Doreraj et al. And Song et al., where they have done all goniosynoculisis also along with the goniotomy. And our baseline IOP was 24, which reduced to 15.2 at 6 months, and AGM was 1.4, which reduced to 0.8. This was intergroup comparison. The intraoperative and postoperative day 1, hyphema and corneal edema was the notable complication of our study, which was managed conservatively and was cleared by week 1. Hyphema was the most common complication noted in studies by Doreraj et al. And Song et al. Conclusion: phacoemulsification with KDB is safe and effective for IOP control in both PACG and POAG group with visually significant cataract. The procedure reduces IOP and the need for AGM. Advantage of decreasing the number of topical AGM would be an improvement in compliance, reduction in the medical treatment cost, and decrease in the ocular surface toxicity. Limitation was, since it is an ongoing study, at present the current sample size is less and follow-up period is minimal. Thank you, and these are my references.
You are not compared with the cataract alone cases, no?
No, sir.
IOP reduction, because that also is expected, no?
Sir, it was
What I am asking is, if you compare this group with a cataract alone without a KDB.
Yes, sir. The reduction is in our studies have shown that reduction is much lesser when comparing with the KDB.
No.
So since
I agree with the previous studies, but if you have another limb comparing that thing, that will give a more clarity.
Maybe we can consider, sir, because it's an ongoing study. The follow-up period is 2 years. We can include that also, like a separate arm. We can consider.
Whether the cost of KDB is affordable or the medicine?
Initially, we started with a single user, but when if we are not getting much patients, we did
multiple use.
Yes, sir.
Okay, thank
Up to 3 we have done, sir.
Good, ma. But do you think this is going to be long-term permanent solution?
No, sir. The aim was in our
Your
study.
follow-up is less.
Yes, and in our study, the group was having mild glaucoma. Okay. So instead of giving them one medication, anyway they are undergoing cataract surgery. So this procedure reduces chance of medication-induced side effects in such patients, sir. So since the follow-up period is 2 years, we can manage how we can understand how their IOP is increasing over a period of time, whether it is a permanent solution or it is a temporary measure.
Whether they will need a anti-glaucoma surgery.
Yes. Okay. Whether they need an AGM or an anti-glaucoma
surgery. Sir said no. Your result with the normal cataract, normal cataract reduces. Yes. But were all the cataracts the same type of procedure? SICS, phaco or anything?
Phaco. All the cataract was phaco.
Phaco. So basically, if you had compared phaco alone with this, yes, then it will show additional advantage of this, and long term will tell whether you will need for an alternative. Thank you.
Is there any difference in PACG and POAG groups with the Kahoot?
Madam, up to this period, we have seen that the PACG group had an increased IOP reduction.
PACG behaved better way.
Yes,
madam. Than POAG.
Yes.
How much difference?
Madam, in POAG group, the 20% reduction was 89 in POAG group, but the 20% reduction from the baseline was 95% in PACG group. So, but the number is different, madam. Number was 20 in PACG, 37 in POAG.
The PACG, how long the patient is on medication, or what type of PACG? Directly going into PACG or after
all patients were having chronic angle closure glaucoma, post-YAG laser PI, and was on at least one AGM.
Is there any difference in the subgroup analysis, PACG, synochial closure or creeping angle like that? You have not done?
Not done, madam.
Okay.
Thank you.
Thank you to the speakers. Thank you, judges. We've got time.
Thank you, all of you. All the presentations were good. Thank you so much.